Hello everyone, this is Dr. Minister again. Let us now discuss about sickle cell anemia. Okay, what is the cause? It is caused because of single point mutation in chromosome number 11 for beta globulin gene. Okay, what happens here is beta globulin chain. There is a substitution of valine from the glutamic acids. You can remember by the valine wins over glutamic acid at sixth position of beta globulin chain. It follows autosomal recessive inheritance. Okay, so if there is homozygous presentation, then the disease symptoms will come. In heterozygous condition, it is called a sickle cell trait. So it generally does not exhibit any symptoms. Coming to the pathophysiology is first one is main thing polymerization of HbS, that is hemoglobin S. Okay, so in any stress like any low oxygen or dehydration or any infections like hypoxia, acidosis, dehydration, what happens is this HbS undergoes polymerization, causing RBCs to deform into sickle cells or sickle shaping. Okay, now the sickle shape, what will happen is it will cause vaso-occlusion. The sickled RBC are less flexible. Okay, they will cause blockage in the small blood vessels. Okay, resulting in the vaso-occlusive episodes like pain, tissue ischemia, or organ damage like stroke. Okay, hemolysis will be there, as we know that sickle cells are very fragile, as I said, and they have shorter lifespan, only 10 to 20 days. Normal RBC span, as we know, it is 120 days, isn't it? Which will lead to chronic hemolytic anemia and presentation of that. Chronic inflammation, because of continuous, there is a vascular injury, hemolysis, ischemia happening, right? So it will promote the pro-inflammatory state. Further, it is like vicious cycle, exacerbating the vascular complications. Now, what are the clinical manifestations? One is anemia, that is hemolytic anemia. So patient will be having fatigue, pallor, and jaundice. Here they will be having reticulocytosis. Okay, reticulocyte count will be increased as there is a hemolysis going on. Next is vaso-occlusive crisis, pain. So it will affect the bones, abdomen, chest, joints, etc. Okay, because of the blocking, sudden blockage of the blood vessels to the tissues. Okay, so what are the triggers for vaso-occlusion? As I said, any hypoxic state or any triggers like infection, dehydration, cold exposure, and stress. You have to manage that. You have to tell the patient that these are the triggers for your disease. Next is acute chest syndrome. It could be because of infection, fat embolism, or any pulmonary vaso-occlusion also. Any reason can be there. And patient will present with what? Fever, chest pain, cough, hypoxemia, pulmonary infiltrates, dyspnea, etc. Next is splenic sequestration crisis, because of there is a sudden trapping of lot of sickle cells in the spleen, leading to the splenomegaly, acute anemia also, and hypovolemic shock. So this is, we have to manage very carefully with the hydration. Okay, so even this can lead to autosplenectomy, especially in the young patients. Okay, because of the repeated infarction of the spleen. Next is stroke. Both ischemic and hemorrhagic stroke can be presented, especially in the children. So stroke in young, one thing you have to suspect for sickle cell anemia. Okay, it is associated with increased cerebral blood flow velocity. Okay, we can detect this by transcranial Doppler ultrasound. Now coming to the infections, there is a repeated infection, especially because of autosplenectomy, right? Asplenia is there. So capsulated organisms, as we know, Streptococcus pneumonia, Haemophilus influenza, that are common. One more is osteomyelitis, that is infection of bones, especially with the Salmonella species. Okay. Next is avascular necrosis, because vaso-occlusion of the arteries to the bones. Okay, like then example, infarction of the femoral or humeral head. Okay. Next is renal complications. What are those? Papillary necrosis can happen, proteinuria even can eventually lead to CKD. So hyposthenuria will get, that is kidneys are not able to concentrate the urine. Okay, which will lead to nocturia and increased dehydration again. Priapism in the males, because of blood trapping in the corpora cavernosa. Okay, painful erection of the penis. Next is chronic organ damage. So any organ damage because of vascular damage, it will happen, like pulmonary hypertension, liver injuries, or cardiomegaly can be there. Now coming to the diagnosis, the main gold standard diagnosis is hemoglobin electrophoresis, where you demonstrate what? HbS. Okay, next is peripheral smear. You can go for, you can see sickle cells, RBCs, target cells, and whole gel bodies because of asplenia. Whole gel bodies are present in asplenia, right? Other than that, you can go for CBC to see anemia, elevated reticulocytes, that is reticulocytosis, and also granulocytosis, that increased WBC will be there. Okay, now coming to the management, general features, measures. What we have to do is hydration. Then the pain management, and you have to treat the triggers, that is infections, with broad spectrum antibiotics, and you have to tell the patient to avoid the triggers like crisis, dehydration, cold exposures, or any stress. Okay, Then pain management, you can go with opioids like morphine. You can go 0.1 mg per kg per day, like that. No, like every 3 to 4 hours you have to repeat the morphine injections, or you can go with ketorolac, NSAIDs, okay, and fluids. These are all how you manage the pain crisis in the sickle cell anemia. Next is hydroxyurea. So what is the mechanism of hydroxyurea here? It increases the fetal hemoglobin levels. Okay. Now when you are increasing the fetal hemoglobin, it will reduce the sickling of the HbS hemoglobin and the hemolysis itself. What is the dose? 15 to 35 milligram per kg per day. Titrate to maintain the desired hemoglobin and absolute neutrophil count. Yeah, that is how you monitor. Next is blood transfusions in severe anemia or acute chest syndrome or stroke where there is hypolemia and all. Okay. Next is bone marrow transplantation, that is hematopoietic stem cell transplantation, which is very only feasible in the young patients with matched sibling donors. Okay. Because there is a significant risk also graft versus host diseases and long-term complications of it. Okay, this is the only curative therapy for sickle cell anemia. Only curative therapy. Okay. Other than that, L-glutamine, okay, it is FDA approved, which reduces the oxidative stress. Okay. Next is crizanlizumab, which inhibits the P-selectin. So the addition, these are the addition molecules as we know, P-selectins, E-selectins. So additions will be reduced, sickle cell vaso-occlusive crisis will be less. Okay. Next is voxelotor. Voxelotor, what it does is, it increases the hemoglobin's affinity for the oxygen. Okay. By that, it will prevent the HbS polymerization and reduces the hemolysis. Okay. So this is the discussion about sickle cell anemia, guys. Thank you.